We're going live. And we are live again. Welcome to Tales from the Heart, episode 2 for June 13th, 2025. And I am absolutely delighted to bring somebody that I've known a really long time, but nobody in the HCM community, well, maybe some of you know who he is, but I am welcoming Dr. Sam Sears to Tales from the Heart, a podcast from the HCMA. Good morning, Sam.
Hey, good morning. Great to be here.
It is great to have you. And you are a name that probably isn't very well known in our HCM community yet. But I wanted to take the opportunity to really introduce you to our community properly. Sam, I hate to actually say these numbers out loud because I know how they make us both feel. We met like somewhere between it's like 26, 27 years ago.
Yes.
And immediately I'm like, wow, I hope I can work with him at some point. But we were just a baby organization with no infrastructure and we didn't really know where we were going to be at that point because it was the 90s.
Yes.
Which just makes us sound really old to the young generation. So Sam, what are your memories of how we came to meet?
Well, my memory was meeting you at the table at the then NASP, which is now called Heart Rhythm Society meetings. I believe it was in San Diego. And I had wandered into the exhibit hall and you all of the patient groups were kind of over in the corner, away from all of the people that I guess had paid a lot of money to be front and center. So I wandered over your way and introduced myself as a psychologist at this specialty cardiac rhythm meeting. Talked a little bit about what it is I did, and then you shared your story about both yourself and your sister, and my jaw hit the floor because it hit the floor because of the authenticity, because of the intensity, and because of the depth of emotional involvement. And those three things just smacked me. And I think it's maybe because I didn't really know what to expect, but that hit me in such a way that as a psychologist, it was very clear and obvious to me about what your heart and soul was about. And it's the same heart and soul that I have about empathizing, empowering, and overcoming the best you can while acknowledging tremendous challenges. It is not a Pollyannish process. It's a hard one, day in, day out, acceptance, engagement, fighting, recouping some degree of control and being fully aware of all that's come into your life and out.
So I find it a bit cathartic that our first podcast together is on my most unfavorite week of the year, because this is where it all started.
Yeah.
And we're at a milestone year this year for me, which is 30 years. And I think back to the confusion, the grief, the turmoil that was going on in our family and in my life at that time. And I wanted to solve a problem. I had seen generational grief. I've seen, I never met my grandfather. I never met my great aunt. There are people that just died too early. I didn't get a chance to know them. I hear stories. And here I am now with my sister at 36 years old, deceased. And I wanted to do something. Somebody should do something to stop this problem.
Oh.
And then nobody stood up. So I did. And I had no idea what I was in for because you couldn't predict all of the things that would happen.
Yeah.
But I remember meeting you at the booth and you're like, I'm a psychologist and I work with device patients. And I grinned to myself. I'm like, can I hide my true identity for a little bit? Will he know I have a device? So we kind of had this lovely conversation and you're like, oh, you have a device. I was like, yeah, I do. And I remember the look on your face. Like, I think I was the first wild type ICD that you might have run into, like out of the clinic. But that's the way it struck me at the time. Probably not true, but you're like, you're one of you're one of those. And I'm like, yes, I am. And I found your questions to be very different than everybody else at an EP conference.
Hmm.
They wanted to talk about technology, and you wanted to talk about the lived experience and how I was coping with it. And I'm like, nobody asked me that.
Hmm.
Nobody talked about how I was coping. I'm just coping.
Yeah.
So it was refreshing to know that you were there. But I think what our listeners are going to be really interested in is, what is your body of work? Like,
Hmm.
what is it about cardiac patients and device patients that interests a psychologist?
Sure.
So tell us a little bit about it.
Yeah. Well, over the last 30 years, I've been in practice as a psychologist embedded in cardiology with the primary focus on adjustment to ICDs. Now, you don't stay there, right? You go all the way up and down the continuum of heart failure, you go up and down all the continuums of channelopathies, you go up and down the continuum of families and spouses and siblings and return to work and return to sex and return to play and return to this, that, and the other thing. And so it turns out to be just an incredibly rich fabric of clinical experiences. But as this time went on, both 12 years at the University of Florida and now 18 at East Carolina University, we've developed a massive body of work about the psychologic aspects of living with technologies in the cardiac space. At this point, most recently, I was ranked 11th of the all-time contributors in research related to ICDs and 42nd all-time in contributions to cardiac electrophysiology as a field. What's funny about that is, like, I'm a psychologist. They let me slip in the side door and I took over. Just kidding. But
You
it
might have
means,
something in common.
yeah, but it means, yeah, exactly. But it means that the kind of work we've done, both being highly productive, constantly grinding and driving on trying to understand questions, creating data, summarizing data, communicating for physicians, nurses, patients, spouses, policy, constantly writing and communicating, doing all the things that you've also done. Our careers are very much parallel
Parallel.
in this way. Today, we have over 250 publications in the medical literature around ICDs, around almost 14,000 citations around these kind of things. The librarians give me these numbers. And so all that means is it means nothing to me. I mean, it's an honor, but we got to still have so much work to do. And that's why you and I are talking on this call today, and some of the things we'll talk about by the end. Because we got more to do. We're nowhere near where I want to be. The problems are more refined. The challenges are more clear, but we have so much more to do.
So great segue. We're working on something, and I want to do a little bit more background, but this is the tease. We're working on something, and I think you're all going to like it. It's going to take a little while to get together, but we've got an idea here.
Yeah.
So when I first met you, I didn't think about the mental health aspect of HCM at that point. I was living in grief. I had just experienced massive trauma.
Yeah.
I had the disease myself. I was pregnant when my sister died. Like, there was a lot going on. And 30 years later, I can finally, I honestly think I couldn't see this clearly until now. It took me 30 years
Mm.
to realize how much changed in those 5 days of Lori's cardiac arrest, her deterioration, and her becoming an organ donor. How much changed in 5 days in my life, in my psyche, in my person, and how I learned to cope and function. I had to work on like 10 different levels at once. I couldn't do one thing, put it away, go to the next thing. Everything dropped on my desk at once, and I had to figure out how to manage it. And that wasn't fair. I shouldn't have done that to myself. I should have reached out for help sooner. I probably would have made different choices, but it landed where it landed, and I'm okay with it now. But I understand that I've been functioning at this very, very insane level for a long time because I was conditioned 30 years ago that that's what I had to do to survive.
Yeah.
And I know I have a team now and I have a lot more partners, and I don't have to do it all myself, which is beautiful. But as you and I discussed, we are both not early in our careers, but we're not done yet. And in the time that's left, there's things that I want to contribute to the body of work. And a couple of weeks back, Sam got a random Lisa voicemail. And it was, I don't know the last time I had talked to you before that. It'd been a year or so probably.
Mhm.
And I leave Sam a message. I'm like, I got an idea. I got a project. We need to talk. Here's what I want to build. And I basically left the entire outline on your voicemail. I'm like, we're going to do this, 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 this. Want to play? Call me back. And he did. And I am happy to tell you all that we are beginning a partnership to build something called the Hearts and Mind Mental Health Network. We are in the early stages of seeking funding to build everything that we need to build, but I don't think it's out of our reach. It's definitely in our wheelhouse. And we want to provide educational programming to therapists and all behavioral health professionals, no matter their level of degree, better tools to help understand patients like us in the HCM community and the things that we need help navigating. And the body of work that Sam has already created to build this educational module will be a challenge, of course, because it's complex data, but we can provide the education so that we can provide a network similar in structure to our HCMA Recognized Center of Excellence structure. Some of the mental health professionals will be embedded in those programs and some will be available to the public. Anybody who's in the field can take the course. And Sam, updated news, didn't tell you yet, we have international interest as well. I saw
Fantastic.
some amazing people this week from Mexico and Portugal that
Fantastic.
would love us to offer the program to them as well. So, Sam, why is it important for HCM families to get mental health support that is tailored to understanding cardiac disease in these families?
Well, let me say before I answer the question, I admire the processes that you've been through, and I admire how far you've come in all these years. And like you said, I think part of what we have to do is not not create. Let's not have it this hard for everyone.
Right.
All right. So let me just answer your question very directly. Things that affect the heart affect the mind.
Yes.
Okay. So if you have been diagnosed with any heart-related problem, because actually it turns out a lot of the benign heart conditions have significant distress associated with them because people are like, "What just happened to me?" So the shock value of being diagnosed with a heart problem has some implications, and if not dealt with pretty effectively, they persist and become part of a highly fearful response to any sort of bodily sensations. You end up being like a body listener. It's like having headphones on, but all you're listening to is your heart rate and your blood pressure and worrying about checking all the body symptoms all the time. So the bottom line, why I think this is important and why we need specialty mental health care is because one of the challenges is feeling isolated. So you have this problem, you go to maybe a big time university medical center that's got a brand name. They tell you you have this condition and they say, well, we'll put a plan together, and you walk out the door. Who do you, how do you manage that information, content, affect, emotion, behaviors? What do you do? And one of the worries that we've had, that my work over the last 3 to 4 or 5 years has now begun moving away from the roughly third of heart patients that have a diagnosable condition and trying to move to the 100% that have some effects, right? So
Right.
because if it affects the heart, then it affects the mind, 100% of people. Now, for a third of those people, it's diagnosable and is probably even somebody who's a very traditional mental health provider would say that's an anxiety problem. But what we want to do is demonstrate that the psychologic experience is universal. Everybody has some reaction, that it's normal, that it can still coincide with hope. You don't have to somehow feel like you have a foreshortened future, and that we can put a plan in place that's supportive and builds a positive future. So specialty services are necessary further just because the uniqueness of the stressor, the uniqueness of being told that you have a cardiac condition, and in many cases, such as this one, that there's a genetic component and therefore it has a family component. And so people want to know what the future implications are.
We are a group of individuals who many have been told that they have anxiety as their primary diagnosis, which has thrown many of them into being a little sensitive about the word anxiety.
Yeah.
My father was told he was an anxious boy, and he went to his GP, good old Doc Karate in the little building back in the day. Oh, you're an anxious guy, Larry. Here's some, oh God, I forget what the drug of choice of the
Probably
day was.
Valium back then.
Valium. It was Valium. Yes. My
Yeah.
father was on Valium and diuretics for most of his life. And he was told that that was his problem.
All right.
Turns out when my dad was about 57 years old, he was diagnosed with HCM after all of us had been diagnosed.
Yeah.
So he was the last one in. But when you talk about being told you have anxiety for a long time and it was really your heart, then you're told it's your heart, but then you get anxious.
Right.
It's this,
And when?
how do I deal with all of these emotions? And, I kind of say it somewhat laughing, but, are we crazy? Are we stressed? Is it our heart? Is it our mind? There's a lot going on. And unpacking that isn't the core competency of cardiology.
No.
So we have learned that we have to go beyond cardiology for this assistance. The practitioners in cardiology don't have the skill sets or the time to
Yeah.
address all of these issues. So we need other providers in the system. And those are the mental health providers.
Yeah, and I mean, my vision in a perfect world would be that because everything that affects the heart affects the mind, then if you're being treated for a heart, then you need to be treated for the mind at the same time. Not in some sort of handicapping victim way, but rather saying, hey, we got to keep your mind sharp because it's easy to get down in the dumps. It's easy to worry about the future. It's easy to feel like you don't have what everybody else has got. And we've got to make sure that you don't fall into the trap of victimhood and fall into the trap of you're in constant danger. Heart problems today need to be dealt with, and so does psychological distress. We simply need to deal with it, uh, and we've got to put people in place who are ready to do that.
And I do believe there is an entire ecosystem waiting for this training. We've been in talks with some other larger mental health provider organizations to embed our education when it's ready. And we're having those backdoor talks right now to see who our partners are going to be. We're talking to our centers of excellence to identify the people that require the training or to put additional people on our steering committee at this point as it's still being formed. And it's a little premature to come out and tell you about the project, but I need you to understand who Dr. Sears is and why you're going to start seeing this name more and what we're working on. We hear you. I've heard you for 30 years.
Yeah.
We've provided some level
Yes.
of mental health support
No
in
question.
education.
Yep.
But we need to formalize that. We need a bigger team. We need a bigger boat, a much bigger boat.
Well, hats off to you again for recognizing yet another need in this space. I mean, part of the reason that you've been successful is you've identified target places that needed help and then built teams around it. And to me, this is just the next in your pursuits because it's time for this. And what's interesting is that this is not built for any other heart condition either. And hypertrophic patients would be a great place to start. You're certainly a driving force in this area. And so it seems like the time's right, players are right. So this might be just the right time to say our goal is that every patient who needs to have some degree of psychologic support can find it within a reasonable process. Might be telehealth, might be within the state, might be local, but whatever, we're going to build a plan.
So as structure goes, what we're trying to build is something that can be virtual or in person because people have very strong opinions on how they want their mental health services delivered.
Sure. Good.
And and I think it's also important for listeners as we're building these programs to provide us with feedback, things that you would like to see involved. That would be great. We want to work with payer systems so that we can just go through your insurance and you don't have to worry about how you're going to pay for this. Unfortunately, that tends to be the barrier for a lot of people into getting this type of care. So we want to make sure that it's in network and that it's provided and that there's lots of different options because one size is not going to fit all. We started with, 5 or 6 HCMA recognized centers, and now we're up to 56. We'll be 60 by the end of the year if all goes well. So
Awesome.
that model of systemizing, organizing, deploying, we know how to do that. We know how to do that very well. So how do we do that with mental health professionals and give them the type of insight that they need from your perspective and your colleagues? So we're excited to pull together the steering committee and really start getting to work on building the curriculum and the data. I thought I would just ask you a bit of a more practical question. So we're going to build a program. We're going to do a thing. Give us 9 to 12 months probably till you see something ta-da be launched for that, but this is kind of your precursor. A lot of patients with HCM, I'm going to stick into your core competency where you started from with devices. I have a very dear friend, doesn't have HCM, but is getting an OCD this weekend, or today or Monday. I don't know which day it's going in. And every week there's somebody new in the HCMA that gets a new device. I try to explain that they need to be ready to accept the device as a friend, not a foe. It's not an invader. It's a companion. Like there's words that I try to get them to use so that they don't fear the thing that's inside their body. And a lot of people are nervous about having something in their body. Um, I have a leadless pacemaker in my transplanted heart. I'm kind of over that now. I'm good with it. I love cardiac technology. But for somebody who's new to it as a psychologist, what are your welcome to ICD world what's your opening volley?
Well, number one is to get you, the goal is to help you feel safe, and the purpose of the device is to keep you safe, So the number one psychologic target is feeling safe again, because as you know, heart disease feels like a thief, right? It breaks in, tries to steal your sense of self, your sense of future, your sense of security. And so we start with the idea of the target should be to feel safe again. Now, how do you feel safe? Because that sounds like a bunch of mumbo jumbo, but this is a really important idea, because safety, you can't give people false safety. So does the defibrillator work? Yes, we know that very clearly. Do the medications help? Yes, we know that very clearly. Does remote monitoring help? Yes. So starting to put together those 3 parts of the safety net right there, plus you have doctors, nurses, and systems in place, plus a primary care doc, and maybe even a psychological or mental health counselor. So altogether, now you have 5 or 6 different aspects of the safety net to get you back on the perception of feeling safe. But safety is both a feeling and a behavior. So the second part of safety, besides that safety net, is to behave in ways that you feel safe. So test the limits. Now, what does that mean? Well, it means getting back to the idea of exertion, getting back to this perception that your heart is beating fast, but that doesn't make it irregular. And separating out the idea of exposing yourself to exertion, exposing yourself to an elevated heart rate, and recognizing that's good. That's good. Now, I don't mean a dangerously elevated heart rate. That is going to be hard to get without it being way out, right? We're going to use medicines, we're going to use devices, we're going to be smart about how we take care of patients in order for them to return to activity fully, safely, effectively, and as naturally as possible. And as you know, the most recent data says we got to get people up and moving even more than we thought.
Yep.
So, and they won't always get the same message. Not everybody's read the most recent clinical trials. So some people will be out there, some perfectly well-meaning doctors will be out there saying, oh no, shut it down. And it's like, no, that's an old story. So
Your timing is impeccable. We just finished podcasting with Marty Marin, and we were talking about
good.
exercise and how everybody should be moving and
Yeah,
what safe is and all of that. So yeah, we need to get our sense of self back.
that's right. So there is this sort of mental safety, and then there's this behavioral safety. I think information plays into both of those. You got to have good information. Your group's been, the top of the line for that for a long time. So safety does both is both a inside and outside observable thing. And
Mhm.
but that also gets at this point that all patients have to deal with that. I mean, we're not just talking about anxious patients or sad
No,
patients. We're talking about all patients in the cardiovascular space needing to find a way to both feel and do safely, and feel safe. I don't mean hold back. I mean to feel safe as you return to life. And that is not easy. Anxiety is the door jam there that tries to block in both. It tries to get you to think about what if, and it tries to get you to think about, oh no, it'd just be better if I just stay here and stay home and I won't feel anxious. Except if you do that day in and day out, then you don't feel anxious, but you don't have much living. And so, as you know, when we approach anxiety, anxiety increases in the short run, but decreases in the long run. So, getting over that hump of anxiety, getting over that hump of grief, getting over that hump of fear, getting over the hump of lots of things that are scary to us often involves approaching something that's fearful, allowing yourself to feel anxious, but going and doing it anyway.
I want to bring another word in.
Yeah.
Anger.
Okay.
I feel a lot of people are angry at the disease and they don't know where to direct that anger because it's a biologic process and they don't know where to sit their anger. And
Sure.
then it festers into fear. So anger leads to fear, leads to, and it's this trickle. We're all angry up front. Who the hell wants this diagnosis?
Right.
Nobody
Right.
does. I
Right.
don't
Right.
want to do this, but you're doing it. You don't have a choice. You're
Yeah.
here. So can you talk a little bit about anger and maybe acceptance?
Yeah, so anger is a little bit different. You don't hear psychologists talk about that as much because we don't have a diagnosis. We don't give somebody angry disorder, right? There's no such thing. The world gives those people diagnoses like Karen or Ken's or whatever that, right? That's where anger gets diagnosed on TikTok or whatever on some platform.
Funny, yeah. You're
But
right.
but the point is that anger is very much an invalidated emotional expression. So people get angry, and in the instances that you see on TikTok at an airport or in the store or something, people get angry because they're invalidated by their experience. Someone either says to them, "You can't feel that," or "You shouldn't feel that," or "This is not the way," and then or they feel something and the humanity of that experience. I'm sorry that's happening doesn't get validated, so it escalates. From a psychophysiologic standpoint, anger and anxiety live very much as brother and sister. In fact, the body doesn't really know the difference in some ways, meaning that we basically interpret that arousal process of anger or anxiety. We interpret it and we color it based on the perception of feeling fear, frightened, or feeling angry. But the body can only go accelerate or decelerate. It doesn't really have a great
Those are the
sorting.
nuances.
Yeah, right. So from a psychophysiologic sort of neurochemical process, both are real similar, and I think people can misattribute anxiety and anger sometimes. Uh, but and there can also be sex specific ways of expressing it. Somehow it's easier for some people to say I'm pissed off, and it's easier for some people to say I'm really scared. But both have that sort of hyperarousal response. They're both perfectly normal responses, but when invalidated, when dismissed, they can often be exaggerated or elevated or magnified. They persist because they don't get hurt. It's sort of like a kid throwing a tantrum to simplify it, right? A kid doesn't get what they need, so they throw a bigger tantrum as a way to make sure that they've communicated that their needs weren't met. Now I'm being a little silly, but that allows us, when you talk about kids or animals, uh, they don't use words like adults might, and so they show you their feelings more often than they speak of them. And anger and anxiety lived very much. They're certainly next door neighbors if they're not brother and sister, or I don't know, however you want to equate them in some way.
I think they're brothers and sisters, and I think they can be. I think some people have a very difficult time separating them.
Yeah.
And in the 20 plus thousand patients that have contacted the HCMA, or families, I should say, there are some of them that come in really hot and they're angry at everything. They're angry at us because we didn't answer the phone fast enough. They're angry at angry, and
Sure.
there's just a lot of anger. And we try to diffuse that and give them power. And
Mhm.
when they have power, how do you give them power? You give them information. Give them information. Now they have some power. Then they stop being so angry and so scared. And then they work on their, okay, what next? I don't think I've ever dealt with anybody who said, I got diagnosed, I'm perfectly fine with the whole thing. And like, I've got no concerns, no stress, no worries. I don't think that person exists. But there
No.
are families who are like, oh, yeah, my mom, my sister, my cousin, my aunt, now me. So they don't feel like it's not, why me? Well, because it was them too.
Yeah.
So when we deal with familial disease, so now we've got the individual, and we kind of talked about that a little bit, but now you're in another role. You're the
Mm.
parent, you're the child, you're the sibling, you're the niece, nephew, aunt, uncle, you're the whatever. And now you're dealing with it for your whole family. And maybe sometimes people don't coordinate their symptoms or their flares very well. And you've got one family member dealing with this issue and another family member living with that issue, and you're diagnosed too, but you're okay at the moment, but they're the ones with issues. How do we manage psychologically separating ourselves from the others in our network, our family network, and not just live in like, what's the HCM status of everybody today? Like, how do you get past that? I know I've done it, but I don't necessarily know that I've done it the right way. I did it my way.
Sure.
How do
Well,
we
let's
help others?
establish the problem. The best studies we have that are meta-analytic studies, so there are many studies compiled on each other, suggest that at least spouse data, which is the easiest way to compile the family effect, is almost exact to the patient levels of distress. So that in the most recent meta-analysis, the rates were 22% for spouses being diagnosable anxiety status post any number of arrhythmic conditions. So it wouldn't have been hypertrophic only, but just any number of ventricular arrhythmic conditions. So we know first off that the question's a good one. Spouses do in fact face substantial disruption, distress from the diagnosis. That's number one. But today it's way more complex, as you mentioned at the end, which is now we have genotype positive and phenotype negative and vice versa, and blah blah blah. I'm no genetics person, obviously, but my tease there is that now we have people. Oh, I don't have it, but they do, and and so these differential experiences now are occurring in families. But the bottom line is that um, this is a team sport, and empathy matters, and understanding where each other are coming from matters, and that it doesn't make sense to suffer in silence, that that connecting with family, connecting with healthcare providers, even connecting with your association are ways in which people can in fact wrestle control back, wrestle some degree of forward thinking, and go about this with a set of people who can support them, not just one. So it is tougher. Now, what are some of the classic trip ups I see? Well, one trip up I see is you're not coping the way I cope. Why don't you do it that way? That's number one. That happens a lot. Number two is you don't look like you care enough. Okay, well, that can be two. That could be maybe they don't, or maybe they don't know how to express themselves. Yeah, another one is that I just can't deal with this, so I'm not going to deal with this. So there's different flavors of way people, those are just quick and dirty things that we see clinically where people just highly engage or highly disengage. try to puppeteer someone else's coping. You're not doing it my way. That doesn't work. Uh, but I tell you what, the bottom line principle is that families and people do best when they authentically approach the concern and just simply say, I don't know what to say, but I want to be here and talk about it with you as needed. Meaning that
Mhm.
just the respectfulness of each of us have different derivations of the experience, and so what just doesn't work is piling it under a rug. That just doesn't work. That just leads to problems. Now, you don't have to be some crying lily either, but I don't think that that's people don't really do that. What we see, people become these sort of hysterical parts when they feel completely dismissed and invalidated. So I think an authentic approaching and saying, look, maybe you want to talk about this today, maybe you don't. But I want you to know it is important for us to talk about, maybe not this moment, but over time, and that I'm going to be here. And I don't have the answers, but we'll work together as a spouse and a patient to be here for each other. And I was here with you before this happened, and I'll be with you after. I, I mean, I don't know that there's any more profoundness than that. I wish there was, but I'm not the profound guy. I'm just a practical guy saying, let's figure out a way. I believe desperately. You need to know this. As a psychologist that takes care of heart pain, I believe desperately, I mean intensely, that you can experience heart problems and be stronger on the other side of them. I really believe that. And you go, how Pollyannish? Maybe, but man, I've seen it over and over again. And
Yeah.
then I think, in fact, you got to end up treating this as a little bit of a special knowledge. I mean, it might have been unwanted, undesired, unprompted, special knowledge, but there is some transcendence about life's not forever, folks. And some people think it is, and they're wrong.
And we're living in that moment. I think Trisha's comment here, obviously, we can't speak to the individual experience, but this is something that we hear a lot. She said her husband had a lot of fear and anxiety with his recent diagnosis. He felt she felt the doctor was not very empathetic, blaming some of the symptoms on fear and anxiety, and it was frustrating for him before. And the bedside manner does matter. So I'm going to unpack this one a little bit.
Sure.
A, not every cardiologist is the warm, fuzzy, like, let me emotionally get you to where you need to be.
Yeah.
They're kind of like plumbers and electricians.
Mhm.
Ma'am, this is what's broken. This is how I can fix it. This is what we're going to need to do. And in America, this is how much it's going to cost. So it's much more pragmatic,
Yeah.
and it's something that they do every day. So sometimes they may forget that this is all new to you. And while I would like to say that every doctor can just clear their mind and go, oh, this is a new one. I have to put my new patient face on here and I have to do all the things. They don't always have the time.
Yeah.
Sometimes their nurses do, sometimes other people on staff do. So I'd give the cardiologists a little bit of grace because this is not what they're trained to do. They're plumbers and electricians. The electrical system isn't working. Let's do these processes with devices and therapies. The muscle's not working. Let's do this. Plumbers, electricians. So, Trisha, as you say, your husband had a lot of fear and anxiety with his recent diagnosis. Completely normal. The first 2 years for a diagnosis are very complicated times for an HCM patient.
Mhm.
They are coming to terms with new vocabulary,
Mhm.
appreciating that the things that they felt in their body that they thought were normal are not normal, and that they have a reason and a definition and a path to make it better. In HCM, there is always a path to make it better.
Mhm.
For 5% of us, that's a heart transplant. For 95%, it's devices and medications and lifestyle changes. So, how do you get your cocktail right? The right amount of exercise, hydration, medication, and mental well being. It doesn't happen overnight.
Mhm.
And this is why we think it's so important to build a medical education program for providers in the mental health space to begin to understand our needs as a community. We've not done that yet, and we're going to correct that. And in the next short while, we will create that education module. Then we got to get everybody to take it.
Mhm.
So you're all going to have to help us on that one. We got to get it out
Sure.
there. But let's talk for a minute about those first it's 2 years. We've
Yeah.
documented this over and over and over again.
Yes.
It's the first 2 years that suck with HCM,
Yeah,
and then we
that's
kind of
right.
get used to it. What can somebody do in those first 2 years to help themselves get through it easier?
Well, let me just validate again what you said. Those first 2 years, there are longitudinal studies. They come to us from the Pacific Rim. I think there's a Korean study that looked at people over time and basically showed the relative risk of mental health problems. In year 1 was the highest, year 2 was the next highest, and then it starts to steady out a little bit more over time from there. So it is the case that, like, part of our guiding principle is to try to help somebody like the post where the first year was really tough. So you're right about that, Lisa. Both your experience as well as the data line up that way. Okay, so what should we do in those things? Well, the first and foremost is to both get good information, right? So we want to get good information and get a very clear working relationship between the family and a cardiac team. So we've got to know, you got to know that the plumbers or electricians or whoever we're dealing with at the moment, they understand the importance of the pipes, and so we want to work together on this.
Yep.
So building a team. Secondly, getting a plan, right? So we got to get out of ambiguity and get to some sureness. Now, sureness can change, but you need at least a short-term plan. So we got to get away from, the breathtaking experience of the diagnosis and move toward, okay, this is what we got. Here's our options. What's the first option we're going to take, and move toward that? Let's get a plan in which, what are the things you need to feel confident and safe? Do you need more information? Do you need support around exercise? Do you need support around your medicines? Do you need support around paying for things? Do you need support around emotions? So what are the things we've got to build a plan that addresses the comprehensive approach? Because I think part of what you just asked me was, well, show me what'll make a difference in the short run. Well, a strong plan medically, a strong plan psychologically, a strong plan behaviorally, and a strong plan to synthesize that and create a team around that. Now, in terms of psychologic distress, right? Again, I think a gentle approaching of those fears that continue to come back around, hey, I know this shook you up in the short run, but I know maybe now you're worried about the impact on family, the impact on your job, the impact on having a family, the impact on spirituality. Any of those things could come in, and so we just have to look for the collateral effects. I mean, because you could say, well, it's just a bunch of cells in my heart. What's the big deal? Well, that isn't the answer, right? I mean, it's the collateral effects. It's all of the downstream effects. So I think the first year has to be around both the acute response, which can be mostly medical, and then unpacking systematically and approaching the other kinds of collateral effects and helping people feel in control and with a cadence, a steady drumbeat of moving back toward a degree of control and a degree of normalcy.
I think that was beautifully said. That first 2 years, you need to give everybody a little bit of grace.
Yeah.
The doctor doesn't know you. They don't know what's important to you.
Yep.
You also brought up something that I think over the years we've talked about here and there, but it's a trigger item for some. When we had a message board back in 2000, remember message boards?
Oh, yeah.
We had the little subsections of the message board. We had the God Squad. And I
Whoa.
had a couple of ministers and a rabbi and somebody else who kind of monitored my God Squad, because how you practice your spirituality is your individual choice. I'm not here to judge. So we wanted to give people the opportunity to be prayed for, to pray for others, to ask for spiritual guidance. And I kind of evolved that to just send positive thoughts, like just positivity in the world. So I think when you are looking at your entire patient experience, we have to face our mortality.
Mhm.
And by facing mortality, we often look to how we were brought up to understand existence. Oh, now we're getting deep. And that leads to spirituality and how you're going to cope with the fact that no, we don't all stay here forever. We have a shelf life and then we depart. How and when? I'm kind of going for like 85-ish in my sleep after my birthday party. That would be nice, but I don't get to call that.
Yeah.
You don't get to choose your death.
Right.
So I've fought death. I've looked it in the eye. I've gone into a transplant OR, awake and not on any medication. And they're like, "What are you doing?" I'm like, "I just wanted to say hi." Because my personal belief is that my existence on this plane will end when it ends. I will do everything I can to stay here. And I
Yeah.
thought I'd get through transplant okay. And if I didn't, what would I know? And that's how I chose to go in.
Sure.
So I thought about it. It had thought. I didn't just show up and go, "Yeah, I'm fine with this." No, I really rationalized my chances of survival versus not, which were pretty good to survive. Obviously, I'm here, but I faced my own mortality quite. Doesn't get much closer than that one. It doesn't. I've survived a stroke and I've survived a transplant. Ugh,
Yeah.
thank you.
It's pretty big.
But my sister didn't survive her cardiac arrest in 1995.
Sure.
Would she have survived today? Probably. We would have defibrillated her sooner. We would have done, um, we would have brought down the body temperature. We would have done hypothermia. We would have done a lot of things differently. So we can do them now.
Yep.
But the family with the disease witnessed the death in such a traumatic way.
Mhm.
Any words of wisdom to families that have survived or that have lived through a sudden cardiac arrest of another? Any pearls to lean into for that one?
Well, it's obviously a significant trauma that is almost unspeakable. So, I mean, it's not just advice. I mean, the research suggests that being able to talk about what you thought, what you felt, how you make sense of it remains the way to deal with that, particularly if you want to, right? So the research doesn't suggest that you make everybody do that because people have their own ways of coping. We don't have numbers on this, but let's say 25% of people go through that and go, you know what, I got it on my own. For me, I'm not a big talker guy, so I'm not going to do that. Fine.
Yep.
But what we've got to do is make available for the people who do need to make sense of it, who the horrific nature of it is persistent on their thoughts, persistent in their dreams, persistent in intruding on non-related situations, and you have those thoughts. We think about, I mean, some really recent data suggests that when you spontaneously ask heart patients what are they thinking about using different kinds of methodologies during the day, that 48% of the time when you interrupt a heart patient that they had just thought about their heart condition, suggesting that the burden of this disease isn't just what we treat in clinic. The burden of this disease might be a lot of the feelings and thoughts that persist out of the frame. And that's why I've turned my attention to the 100% of heart patients and not the 30 that are diagnosed, because I'm convinced that lots of people do great with this. I mean, great meaning they don't get diagnosed, but they also then have changes that they don't know what to do with. So I think the bottom line to your question is, let's get it right for you. That there isn't no right answer, but rather, what do you think you need to be able to manage what you saw or felt? Are you somebody who needs to talk about it? Are you somebody who needs time from it? Are you somebody who needs to talk to other people that have been through it? There are different ways of approaching this and diffusing some of the emotional power and energy that goes with a trauma. I mean, our brains are wired to make sure that if you see a trauma, that let's make sure that never happens again. And so there's this constant warning and alarm process that can go with it. And the more that you try not to think about it, the more you do think about it. And it's just this continual process of avoiding and intrusion and avoiding an intrusion if we don't get after it. So I'm humbled by the traumas that I see in my patients because I don't think there's some perfect way, but I know that relationships, talking about it, communicating about it, empathizing about it, begin us in the right direction.
I didn't realize until you were speaking how much our original conversations actually helped me create the framework that became the service model that is the HCMA.
Hmm.
Because we had conversations very similar to this back in 1999, and you made me start thinking in different ways. And as technology has evolved, we are truly trying to meet each patient where they are with so many different ways of learning and feeling heard. This is one of them. This is one
Yeah.
of the platforms. Podcasting. Okay, let's talk to people about things and let's give that information to those who need it. So, this is one way people can get this information. We have webinars. You want more data? You want to know the citations? Come to one of our webinars. One of our docs will teach you that way. You want to just talk to somebody? We have discussion groups. We have our intake and navigation process that's very individual and very personal. So you can talk out your questions, you can ask for resources, and we've been developing resources. Are we perfect? Nope. Do we have everything for everybody? Nope. Are we everybody's cup of tea? Probably not. But these are the systems that we set up and they work. They
Yeah.
work so well. We want to get you through that first 2 years easier. We want to align you with specialists. We want to give you and your family support. And we want to help you live a normal, fulfilled, happy, optimistic life. I don't have any time to waste in this one wild and precious life on worry.
Mm.
I gave that up a long time ago. I will control what I can control. I will do what I can do, but I will not waste time worrying. And I'm going to tell you why. Because my grandmother did it. My grandmother lived through trauma that I didn't appreciate until I was a parent, probably. She was like 39 years old when her 43-year-old husband drops dead.
Mm.
She's got 3 kids, 10 to 18, and it's the 1950s, and she doesn't really have a job.
Yeah.
So the trauma that she dealt with through that framed a lot of who she became. And then 1953, she loses her husband, and in 1964, her only daughter is killed in a car accident. So she had to sustain that. Then in 1990, one of her children died. Then in 95, her granddaughter died.
Yep.
She went through so much trauma because of HCM. And it was tragic, but nobody ever took the time to talk to her. She was a stoic Catholic woman. We don't talk about our emotions. We're a good Irish Slavic family. Like, we don't talk about bad things because if you say it out loud, it'll happen. She never got the care she needed. And my grandmother spent the majority of her life worrying, just wasteful worrying. Didn't change anything. Don't spend your time worrying. Find what's scaring you and address it and go with your friends. And that's what we're hoping to build with Hearts and Minds. We do have a comment here from, I think that's Marjorie. Hi, Marjorie. Oh, by the way, hi, Sam's mom. We like Sam. We really do. You raised a good boy. So there, I had to do that. As difficult as the uncertainty of the diagnosis was, I celebrated getting one. This is another issue that is very prevalent in the HCM community. There is something wrong with me. Thank God I figured out what it was.
Yeah.
And it seems celebratory.
Yes,
You want to talk about that?
I do. So we have a model in health psychology called the common sense model of psychologic adjustment. And it has different components, but the number one first psychologic principle is to identify what is wrong. And so when you've identified what is wrong, you've moved from medical ambiguity to some degree of medical certainty. Let's put that in quotes, of course, because we can be wrong. But identifying and labeling what is wrong is known to be psychologically relieving. And we all have personal experiences of that. You go to the doctor and you say, oh, I got this in toenails, it infected. And they say, yep, it's infected or whatever. And then you go, oh, I just feel better now that I know. So knowing what's wrong is known to be psychologically first aid, if you will. It's usually the first step in the process. It doesn't mean everything's wonderful. It just simply means that you've moved from ambiguity to some degree of certainty. So that is a relieving process. In short, we have lots of data that we've been working on in my lab over the last year or two, focused on medical ambiguity. And in the cardiac space, when people don't know what's wrong, even if it's only could be a couple of different benign conditions, the potential of a dangerous diagnosis trumps all. And so we're very interested in this concept of moving from ambiguity to knowns. And we've talked a lot about the role of different kinds of technologies to take us out of unknowns and into knowns, even if the knowns are scary. The unknowns are scary and unknown. So lots of evidence for that. So that is a perfectly rational statement, fits with theory, fits with data, fits with science, and it's where we start most often.
It's interestingly, not only Marjorie and many, many, many other people I've talked to, that's how my dad got to diagnosis. You're anxious, you're anxious, you're anxious. Oh, there's something wrong with your heart. My father broke down and cried. My father was not a crier. His whole life, he thought he was crazy.
Yeah.
And he didn't want to tell anybody. And he was afraid of it to come out, that somebody would know he was anxious. And he's like, oh, I have a heart condition. That I can deal with. That was my
And
dad.
I think one of the worries I have in the work of mental health professionals is somehow attributing a medical problem to a psychological problem.
It's
And
dangerous.
we do see that. We do see that. And so one of the things that I really like about my work is that I'm embedded in cardiology. So I know that a comprehensive medical workup has been done, and almost never, and I mean almost never in 30 years have I said, oh, this is all in your head. And I basically have never said that. But I mean, I could argue maybe a condition or two where people had magnified a small symptom that was there into something that terrified them. Maybe I could get there from there, but that's just not the way to think about this. Um, we have to be very careful about attributing anything to a mental health condition if we haven't got every rock turned over from a medical perspective. And I think in your dad's case, um, people stop too quick and say, well, I don't know. I mean, in defense of medicine, perhaps in your dad's case, we didn't have,
We didn't.
cardiac MRI or whatever we think we needed to see. Today we have much better technology, but there are still medical unknowns. We do, not everybody that walks through the doors gets a definitive diagnosis. And so sometimes we've got to have a go forward strategy of, we don't think there's anything dangerous here. We'll keep looking. We'll be careful. We'll notice any changes. But if we just become medical Sherlock Holmeses, we lose our buddy Watson. And all we do is walk around with trying to figure out a mystery that doesn't need to be solved. I mean, that's not none of us are trained as Sherlock Holmes. And so we got to, let Sherlock figure it out. You don't have to figure it out. Your job's to live life. So there is the alternative to that comment, by the way, is the person that says, well, they just don't know what's wrong, and I just got to keep looking. And then they've become a full-time medical mystery. They think they're on an episode of House, or they think they're got to find Sherlock Holmes, medical Dr. Sherlock Holmes to figure it. And boy, you can lose a lot of time just chasing down something. And sometimes we just don't know. There are mysteries in the world still. I wish there weren't, but there are. And so that does happen. So I'm glad that the comment came in the way it was.
Of course, it would come from Marjorie that way because that's her attitude. And one of the concepts that I've been fascinated by in the past few years in this space is the concept of resilience.
Mm-hmm.
Inborn resilience, learned resilience, acquired resilience, or as I have kind of coined it internally here, pivotability.
Mm-hmm.
Like somebody's going to throw something at you. How are you going to address it? Like,
Mm-hmm.
what's the attitude? Are you ready to learn and fight, or are you just going to let it wash over you and it's going to take control? Don't let it take control. You run your life.
Sure.
And that's what we're trying to build here.
Sure.
this network that will help people live the best life that they can live. So we're coming to the close of our hour, and I wanted to thank you from the bottom of my heart, both of them, the one in the box and the one in the chest, for spending this time and taking this journey with us on this,
Yeah.
Hearts and Minds Mental Health Network. Sam, it's not the first time you'll be on Tales from, well, it is the first time you're on Tales from the Heart, but it won't be the last. We're
Thanks.
going to keep talking to the community about what
Yeah.
we're developing. And there will soon be a landing page on the website so you can learn more about the project. This is all kind of evolving as we speak.
Yeah.
But if you have a mental health professional, keep in mind that at some point we're going to be offering CME courses. So we'll probably set up an email list where people can start to tell us that they're interested in learning, and we'll get the educational material out to them as quickly as possible. If you have a personal therapist you'd like to invite to the program, we will be creating methods for that as well. So just stand by a couple more months and we'll have that ready. Sam, thank you so much for joining us on Tales from the Heart. Thanks
Thank
to our
you.
sponsors for making it possible. And I look forward to learning a lot more about what we can do to help all cardiac patients. Yes, we're starting in HCM and thick hearts, but this network will be beneficial to the entire heart community. We're happy to be able to champion it. So thanks so much,
Thank you.
and happy Father's Day.
Cheers.
Cheers. Bye-bye. And we're
Bye-bye.
going to end stream.